So, dear colleagues, dear eye care professionals, dear researchers, dear industry partners, and dear friends, on behalf of the European Myopia Society, it's really my great pleasure to welcome you to the today's Myopia Conference. I would like to thank each of you for joining us from across Europe and beyond, and the important challenge is preventing, controlling, and managing myopia. So I would like also to really thank Learn Society's partners and also industry partners because they allow us to work together. And so this is precisely why EuMYS was created, to bring together ophthalmologists, orthoptists, optometrists, vision scientists, researchers, in a common European platform dedicated to myopia. I would like also to encourage everyone to participate actively in the discussions, ask questions, and share experiences. I would like to address a special thank to our expert speakers that will, and I hope you will find really useful information. And so you can see here the program on the life impact of lifestyle and time outdoors on myopia onset and progression, initial pediatric assessment in practice, why axial lens matters, current evidence on myopia management strategies. And there will be question and answers. And really, I really wish that you can send us all the questions you have. And thank you again to be with you today. And I wish you an inspiring and a productive web conference. Thank you for Annegret. You are the first speaker on life impact of lifestyle and time outdoors on myopia onset and progression. So the floor is yours. Thank you.
Thank you very much, Dominique. I'll just wait for the slides to be coming up. Here we go. So my name is Annegret Dahlmann-Noor. I'm based at University College London and at the Institute of Ophthalmology there and Moorfields Eye Hospital. I can't see my slides at the moment. I can only see the introductory slide. Here we go. These are my slides. So what I would like to talk about today is lifestyle and environment and time outdoors in particular. And the reason is that when parents come to see us, those are topics that they regularly bring up. And whilst we have become increasingly comfortable discussing in consultations the role and the use of myopia, of optical interventions to modulate myopia progression and low concentration atropine, we are maybe a little bit less at ease with the data on time outdoors. So today I would like to summarize what we know. Let me start with a child. So we're all familiar with this scenario. An 8-year-old child comes and presents with myopia of about minus 0.75 diopters. And the parents ask you, why has that happened? How much time should my child spend outdoors? I've heard that sunlight helps. Is it the screen? Should we not have given her a smartphone? Does living in a city matter? And is there anything else apart from glasses that we can do? And then the last question is, and what about her little brother? He's 3. So there goes your whole package of questions that you try to address within one consultation. When we look for answers, if we start with prevention, so prevention is close to our heart, but obviously when they come to see us, it's too late. But for the little brother who is 3, this might be an important topic. So I found this paper very interesting when Bullimore and Brennan calculated that delaying the onset of myopia by 1 year may have the potential to lower the final degree of myopia by 0.75 diopters. Now, that might not sound very dramatic to you, but when you think about it in population health terms, it actually makes a big difference because it means that a substantial number of children will not develop high myopia if we can push back the onset by a year. And the other yardstick to compare it with is if we manage to push back, to delay the onset by a year, then we might achieve the same effect as we do with 2 to 3 years of active myopia control treatment. So for the little brother, it does matter if we manage to delay the onset. So what we know about the risk factors and why they matter and whether we can modulate them is still in the two categories as always. So it's genetics and the environment and what happens in terms of interaction between the two. There is some genetic susceptibility. The more of your parents have myopia, the more likely you are to develop myopia yourself. So if both of your parents have myopia, you've got a higher risk. But that doesn't explain the dramatic increase in prevalence that we have seen over the past few decades. So we know that with the new urban lifestyle, children spend less time outdoors, have less access to and exposure to high intensity light. They spend a lot more time indoors, and when they're indoors, they spend more time on near vision activities, both for education and for leisure. Screens have become very prevalent as well, and we know that in Western countries it is the urban living that has driven the change, and different from other countries, it's also the socioeconomic background, in the sense that it is often the poorer children who live in smaller flats with no access to outdoor green space who are more affected. Does outdoor time really work? And the good news there is that there is really robust evidence by now that it does matter. So it is worthwhile us talking to parents about it. The very first trials that were really important because they showed it's not just an association, but actually it's a modifiable risk factor. So if we act on this, then we will have an impact, were these trials in China and Taiwan. In China, they showed in a 3-year trial that they could reduce the prevalence or incidence rather, the onset of myopia in young children by nearly 10% over 3 years, just by putting them outside for an extra 40 minutes a day. And similarly, the recess outside classroom trial in Taiwan showed very similar figures of about a reduction in incidence of about 3% over just 1 year by having them outside for 11 hours a week, which works out to be about 1.5 hours a day. So what we've learned from that is that it is not just an association, it is a causal risk factor if the children don't have enough time outdoors. And then the COVID-19 pandemic happened, and that was like a huge natural experiment. I like to tell parents about that as well, because from all over the world we got reports that myopia onset was at a younger age in more children. So in the 6-year-olds, 7-year-olds, you see the spikes there shifting to the left. Myopia was becoming more prevalent in the youngest children, and also progression was faster than before the lockdowns. So there was another piece of very substantial evidence that outdoor time matters, because these kids did not have outdoor time, amongst lots of other things, but this was the factor that really unified the observations worldwide. So the evidence became so robust that it could be meta-analyzed and synthesized in systematic reviews, and this Cochrane review really confirmed what we all had seen in individual reports up until that stage. So time outdoors matters because it reduces myopia incidence in the younger ones, and it also has a smaller effect, but it does have an effect on children who already have myopia and who are at risk of progression. So during the pandemic in particular, progression happened much more than before because kids were not outside. So it was nice to see that the Cochrane review could summarize that these findings were consistent from all over the world. Then based on that, cumulative evidence, if you want, countries started to build public health policy and public health intervention programs. I just want to name 2 here. So in Taiwan, the Tian 120 program, which recommended 2 hours a day outdoors for 5 to 6-year-olds, so again, very young children when we talk about myopia, managed to drop the incidence by 50%. So incidence dropped by half just by having the kids outside for 2 hours a day. It dropped from 15 to 8%. And similarly, the National Myopia Prevention Program in Singapore, that's been running for over 20 years now, and combines a public education program, so for parents, grandparents, other healthcare workers, with school-based initiatives, also reduced the incidence, particularly in primary school children, and stabilized the prevalence in children in secondary school. What's important is that these interventions are simple, cheap, and scalable. So if we want to learn something from that, we can take away that probably it's going to work in Europe as well. And we must always remember that the greatest benefit is in the youngest children who don't yet have myopia. So how does outdoor time work? Well, we're not completely sure, but there are some very good candidates in the outdoor light. The most obvious one is the brightness. The light intensity is much higher outside than indoors. When you're outside on a sunny day, you might be exposed to 100,000 lux. Even if you're sitting in the shade under a tree, it's still 20,000 lux. Whereas indoors, it's often 500 lux or less. In the UK, for example, building regulations for schools ask for 250 lux in a classroom. And we've gone round some classrooms measuring the actual light brightness and intensity, and it was even less than 250. So the difference in terms of brightness is on a logarithmic scale between indoors and outdoors. Other factors that might be important are the spectral composition, because our modern windows cut off the very short and the very long wavelengths. The short ones because UV is bad for us, the long wavelengths because they are warm, and for temperature control in the building, the long wavelengths are kept outside. And of course, the visual environment is different outside, the complexity of the scene, the viewing distance, you do different activities when you're outside. So there is a whole raft of things that could be different, but the strongest candidate at the moment is simply the brightness. At the level of the eye, how would light matter? So we know pretty well from lots of animal studies that there is a change in the neurotransmitter release in the retina when light hits the retina. In particular, dopamine has been implicated because the amacrine cells in the retina will release more dopamine when light floods the eye. Other neurotransmitters are adenosine and retinoic acid. Retinoic acid might be particularly important in the transmission of the signal. So we have lots of evidence about what happens in the retina, but the site of action really is the sclera. So there is some signaling cascade that goes from the retina through the choroid all the way to the sclera. And in the sclera is the place where you want to have your effect, because that is where the remodeling happens and the progressive thinning happens, and then the axial elongation. So at the moment, there is still a lot of research being done identifying the players in that cascade, because that might give us other areas that we could target with treatments. This is probably the most common question that we get asked. What about screens? Is it the screens that have caused this whole problem? Well, there is good evidence that near work is associated with myopia. The evidence is a bit less strong than with time outdoors and brightness, just because it's so difficult to measure. Near work is very complex, and lots of different activities happen at a near range. And the screens do play into that, but the myopia increase precedes the development of the smartphone. So we can't really all blame it on the smartphone. But what is different about small screens and what children use them for is that they are not just for education, like their books, but they are also for leisure. Lots of children's social activities now happen on smartphones. And of course, it is also very addictive if they use them for playing and watching short videos, etc. So probably the screens do have a special role to play in the story, but again, it's difficult to measure, so the evidence isn't quite that strong. Evidence for blue light, I think, has been discarded by now, and that might be important for us to know as well and be able to communicate to the parents. Green space. Some people ask what sort of outdoor activity is important, and there is some evidence that it's actually green plants that make a difference as well, not just brightness, spectral composition, etc., but having access to green space matters. So on the slide, on the image on the right, you can see a study that we have done recently here, where we have shown that the children who have got the least access to green space have the highest risk of developing myopia. So there is something in the green space story, although we don't completely know the mechanism yet. But from all over the world, there are reports that children who have less access to green space, or who live in a neighborhood without plants, or go to a school without plants, have a higher risk of developing myopia. What else can we recommend? In terms of screen use, the WHO is very helpful. They have said no close-up screens for children under 2. And I think that's very important to tell parents, because there is now a culture of using a smartphone like a dummy or like a pacifier. So to distract the child, they just get a video on the smartphone. That's probably not a good idea. For preschoolers and primary school children, it should be in the range of an hour or 2 a day. And then there is also the 2022 rule or similar rules, which say that for every 20 minutes of near work, you should relax your accommodation for 20 seconds by looking in the far distance. So whilst the evidence for all of this isn't terribly strong, it makes common sense, and it sort of links in with the association studies that we have. So in summary for my presentation, I've just tried to summarize what we know and how it matters. So outdoor time definitely delays the onset of myopia and also has a small effect on progression. Optical interventions and low concentration atropine are useful, particularly for slowing progression. There they do have a stronger effect than time outdoors. A combined approach has the strongest effect, and we mustn't forget that. So even if we use the active interventions, we should still tell the parents that it's important for the child to spend time outdoors, whether that's going to the park after school, walking to school, walking back from school, having time outdoors during the school day, and on the weekends with the family as well. So don't forget about the combination effect by just adding in some sunlight. And that is it really from me. So thank you very much for listening, and I'm really looking forward to the next talks and then to our discussion at the end. Thank you.
So great, thanks, Annegret. And I think we will go on the questions and answer at the end of the web conference. And thank you very much for the specification of all lifestyles so that our children should be. But it seems to be difficult. So I will tell about initial pediatric myopia assessment in practice and why I really think that axial lens matters. We know that myopia was originally a refractive error. However, we know that's a true disease today, and myopia in children should be recognized as well as progressive myopia. And it's really a challenge because it's increasing prevalence in Europe as well as Asia. And that's really very important to have a deep initial pediatric myopia assessment to be sure that we are not in a bad direction for those children. So I will look at that. We know that in the child, it's not a miniature eye that we have, it grows. And we know also that the child's growth curve is for weight and size. It's well known by pediatricians, of course, and the child growth is developing through percentile curves in weight and size. But ocular growth is similar, and it follows also percentiles. So we have the concept of myopia, blurred vision, and so we have seen it's not a miniature eye, it grows, and it's not only a refractive anomaly, it's a true disease. And it needs to be corrected to improve vision, of course. So we will see that we have a myopic eye and we have myopia control today, which is really great because 20 years before, we didn't have many things to control myopia. And so you can see all the direction, we can see on the eye that increased in elongation, which is abnormal. And the evolution, it's a refractive power in children. So at birth, the child is naturally hyperopic. It tends toward hematropia. And the refractive error is a mismatch between different refractive components on the eye. Cornea, lens, and eyeball axial lens, of course. And so at 6 weeks, we have the refractive power of the cornea decreasing. We have also the lens decreasing in refractive power during infancy, and axial lens increases during infancy and adolescence. And this axial lens growth, this over-targets the focal point on the eye that leads to myopia. So I did a very long time ago a study in MRI for the power refraction of the eyeball. And so we know that the normal axial length of the eyeball at birth is 17 millimeters and around 23 for adults, but of course it varies. And there was a fast growing until 6 months and slow until adolescence. And I'm sure this curve will be very different today. And it's because there is a corneal curvature that varies quickly, the lens power round to oval, and during the development it may occur malformation, and you can see here microphthalmia and coloboma and prenatal diagnosis. So there was a percentile of ocular growth in MRI, but you see 1997. So we have the physiopathology of the myopic eye. So we know that there is a myopic defocus on the macula, but there is something very different in the hyperopic defocus in the peripheral retina. So we need to screen the visual loss risk in children. So we have, it's very important to have eye care professional to do it with ophthalmologists, because we need to see and recognize the myopia in children. And so we can also have recommendations. So we can have that PREC strategy to prevent, to recognize, to evaluate and explore, and to correct and control. That could be an idea and you know, the red wire to go. There is, of course, medico-economic issues in myopia, the visual impairment, blindness, and so we can see 268 billion by year was evaluated, but just look at this child. At the entrance of my hospital, and 20 minutes after, he was at the same position. So that's a big problem. He is really young. There is interesting factors like family myopia, genetics, severe syndromic myopia, and of course disease. Look also, this child again is just 1 hour after strabismus surgery. So I got crazy. And there is also interesting factors. And so thank you, Annegret, because you really show us what was the importance of an environment. So eliminate first myopia disease. 3 tips to recognize myopia disease. So severe myopia or progressive myopia disease, you can just go and see if there is not ROP, juvenile glaucoma, keratoconus. Also syndromic myopia, Stickler syndrome, Wagner disease, Marfan syndrome, Knobloch, Ehlers-Danlos, but we have a lot. And also retinal dystrophies that can be recognized too. And in syndromic myopia, there is congenital myopia and progressive myopia. Just look this child, 6 years old in my consultation, just coming for a myopia minus 0.75. But really, of course, usually associated with increased axial length. And of course, it was juvenile glaucoma, but because you saw this megalocornea, and IOP was 45, so that was crazy. And of course, you must be aware of this kind of disease, and there is a lot that we have to be sure it's not a real myopia disease. You look at this also, Stickler syndrome, it's a congenital high myopia with stenoexophthalmos, and usually minor symptoms and very frequently underdiagnosed. So when you have a myopia onset in children, you need an initial assessment to recognize progressive myopia. So there is an initial workup, of course, visual acuity, of course, refraction, but refraction under cycloplagia, slit lamp, orthoptic assessment, IOP, and it's not so easy in children when you don't have the good device. Axial length is mandatory. Fundus, of course, if possible, wide field. Corneal topography, if possible, also with the corneal radius. And OCT for the corneal thickness. And we probably cannot do everything, but in red, I think this is mandatory. We have handheld devices for children, as you can see here. And also, it's important to have an orthoptic assessment with vergences, stereoscopy, and accommodation convergence ratio, if you can do that. Because when you have azo or exophoria, it's really mandatory to contraindicate the defocus spectacle lenses, phoria or tropia like strabismus. That's very important to have that in mind. We have myopia screening with initial workup, with cycloplegia, mandatory, increased axial lens, of course, and axial lens. You will say, it's also difficult to have axial lens. No, it's not so difficult. All of you have probably access to cataract axial lens measurements. So you do the same for the children, and it's not so difficult. And it's non-contact optical measure, so it's easy to perform. Also, if possible, a wide field fundus and follow-up every year at least. And you can see sometime that even in young children, you see 8-year-old minus 3.25, white without pressure, and 12 years old minus 5.5, tessellated retina. So there is some specific lesions in retina as early as we can see here. There is a spherical equivalent and axial growth, and you see with the Tiedemann publication, the corneal radius of curvature ratio at 9 years old. But you will see also this very important work of the team of Caroline Claver about axial lens growth and the risk of developing myopia in European children. Axial lens you can see here, so you can have an idea how will evolve those children. So when progressive myopia is confirmed, this is important, of course. So what is progressive myopia? Progressive myopia definition fluctuates, but at least when you have minus 0.5 diopters per year and axial lens more than 0.2 millimeters per year, you know that's a progressive myopia. It's also sometimes you can see fast progressors, and this is a specific population that we must individualize because they need a special attention for the treatment. Of course, recommendation for environment, but when you see every myopic child with a progressive myopia should be treated for myopia control, this is very important. Every diopter matters, we know that since Bellimore published it. So we have a customized treatment. We have optical correction, never undercorrection. It demonstrated that it increases myopia. Choice of myopia control system needs something very special. Engagement of the child, engagement of the parents, engagement of the treatment duration. That's very important. And a follow-up every 6 months for control visual acuity and refraction, and control axial lens at least every year. So again, we have a myopia control strategy you can see here. And so you can see correct and control. And you see first, you can have defocus glasses. Then you can have, of course, defocus contact lenses. You have also low-dose atropine. You can have also autoK. And you can have also, which is very important, combination therapy, as underlines Annegret in the previous presentation. It's also, and we have, of course, blue light and red light, and I think Aldo Vagge will present that specifically. So thank you for your attention, of course, but we know that myopia is a public health challenge. We need to prevent, to recognize, to evaluate, and the evaluation should be with inclusion of course, visual acuity under cycloplegia, and also axial lens. It matters really. Explore, correct, and control. Environmental measures for all children. Recognize myopia, and mainly progressive myopia. Of course, recognize myopia disease or syndromes. Define myopia controls system with the children and the parents. They must be engaged both. And we have optical correction, eye drops, combined system. But of course, we need again to have more work to do because we need long studies to evaluate long efficacy and rebound, and they are really still needed. We must work together on this. So I would like to thank my neck ophthalmology team, as you can see here, and Mathieu Robert and Alejandra Darish are from also the team of EuMYS. And really, I would like to thank you for your attention, and I hope you will have a lot of questions to go further at the end of the presentation. So thank you again, and I think now Professor Aldo Vagge will present current evidence on myopia management strategies. So thank you, Aldo, and the floor is yours.
Thank you. Thank you very much, and good afternoon to everyone. Thanks to you, Dominique, to lead our European association. So thank you very much. And okay, let's do today. I like to review with you some current evidence on myopia management. So basically, what's work, what doesn't, and what is new. So I like to start with what we should stop recommended. Under correction of myopia, blue light glasses, bifocal or progressive lenses, and of course, standard contact lenses have all failed to show any meaningful effect on myopia progression. So I like to start also to, I think, the stronger behavioral evidence. We saw the scientific evidence before with Annegret, but I like to stress this concept because sometimes we forget that behavioral strategies are really important. And also, as Annegret said before, outdoor time is supported by a lot of randomized clinical study and meta-analysis as well. And as you can see, at each additional hour outdoor per week can reduce myopia risk by up to 46%. And as we saw before, the key factor is the light intensity. Above 1,000 lux, so as Annegret said very well, it's not necessary to be in direct sunlight, and even sitting in the shade of the tree provide a light intensity significantly higher than indoor. But why? We know that outdoor light triggers dopamine release from the amacrine cells of the retina, and dopamine can inhibit axial elongation. Also, we have the near work. The near work can increase the risk of myopia, and what matter seems to be more the session length more than the frequency at the reading distance. So session more than 30 minutes and reading distance less than 30 centimeters are associated with more myopia. Why? We are not sure 100%, but probably because when viewing near objects, light rays enter in the eye in the more divergent manner as basically an hyperopic eye. So accommodation allows the eye to focus these rays onto the fovea. But however, in the peripheral retina, we have the hyperopic defocus. And we know that hyperopic defocus is a well-known stimulus that may drive axial elongation. And also, we have a lot of data that in a population with no formal education, such as rural community, in Nepal, for example, myopia prevalence is extremely low, often below 5%. In contrast, as you can see from this graph, East Asian educational system, for example, in Korea, Singapore, Taiwan, as you can see, myopia prevalence approaches or exceed 80%. to 95%. I like always often show these slides because I like this striking comparison. As you can see, Singapore and Philippines are only 1,200 kilometers apart, as Genova, where I live, and London, where Annegret lives. But as you can see, the difference in myopia prevalence is enormous. This may mean that epigenetic factor can be more important than genetic factor. But let's talk about optical treatments that, as we know, work by manipulating two signals, the peripheral retinal defocus and probably the contrast management as well. By creating myopic defocus on the peripheral retina, we send an inhibitory signal for axial growth, and reducing retinal contrast seems mimic natural outdoors environment, slowing progression. The DIMS technology is one of the first validated myopia control spectable lenses. It has in the basic version a 9 mm center zone for distance correction, surrounded by 400 tiny segments, each about 1 mm wide, and each delivering plus 3.50 diopter of myopic defocus. That are, as you can see from the picture, spread across the peripheral lens area. The result is pretty good because they can control, so we have a 55% of myopia control of it over 2 years, sustained at 8 years with no rebound effect on stopping and an additional effect with atropine. The HALT technologies features 11 concentric rings of continuous lenslets. Each lenslet is aspheric, meaning it doesn't focus light to a single point, but create a volume of myopic defocus in front of the retina. So the power increases ring by ring, allow to basically to keep the eye's curvature and keeping the focus volume at a constant distance from the retina across the periphery. Our technology is FDA approved for myopia control, and we have an additive effect combining with low-dose atropine. We have actually also the CARE technology that are using annular refractive elements, alternating with the clear zone to the lens surface, creating myopic defocus while maintaining a sharp central vision. In the only randomized trial available so far, they included 234 European children, and they achieved 37% of myopia control at 12 months. And we can notice also that the proportion of fast progressor was almost halved compared to the single vision lens. These slides show the evaluation of the focus-based lenses. We can see HALT max increases the volume of myopic defocus and the anterior displacement from the retina in the dose-dependent fashion, and up to a certain threshold, increasing these two factors appear to enhance the defocus signals. Then we have the DIMS TED, identify a sweet spot that is a peripheral annular zone between 6 and 10 degrees from the fovea, and as the most that they found that is the most effective area for the focus delivery. And as you can see from the graph, stimulating just the zone, so the sweet spot, produce a result comparable to the fulfill the focus. So both technology push the original concept further, driven by a better understanding of a retinal response to the defocus. Then we have the dot lenses that work through contrast reduction rather than the defocus. In the Cypress trial, they achieve 74% myopia control at 12 months, as you can see. And currently in Europe, they are only available in Spain and UK. Also reduction retinal contrast using microscopic diffuser across the lens surface, as you can see, may mimic the natural low contrast of the outdoor environment. Then we have the soft contact lenses and the Ortho-K, the dual focus soft contact lenses that gave 59% of reduction in progression over 3 years. And then we have Ortho-K that orthokeratology provide a great control in terms of myopia progression with an extensive scientific support, but rebound and infection risk must be discussed with family, of course. Then we have atropine. So atropine for myopia control is not something new. Already in 1931, Hallett had reported a work from 1916 where Polo in Glasgow treated myopia children with atropine, reporting arrest or even partial reversal of low myopia. And with atropine, but I can say for other strategies as well, we have a paradox. On one hand, we know that atropine works, but despite decades of use, we still don't fully understand how. Current evidence points to the retina as the primary site of action through muscarinic receptor via a non-accommodative pathway. And 3 clues supported this. Atropine works in chicks whose ciliary muscle has not muscarinic receptor, but only nicotinic ones. Also, bifocal, which reduce accommodation, are ineffective. And research has shifted firmly toward the posterior segment, with the retina and lastly the sclera as the most likely site of action. Low dose atropine, we intend 0.01% to 0.1%, achieves 30 to 60% efficacy with about 10% of non-responders at any dose. Ethnic differences are real and clinically relevant. Asian children respond better than Western children. And this table summarizes the keys randomized clinical trial. Efficacy is consistent in East and South Asian cohort, and results in Western population are more variable. Ethnicity and baseline progression rate are the most important predictor of response. 2026 meta-analysis confirm ethnic differences, 0.01% atropine reduced progression by 66% in South Asian, 35% in East Asian, and 28% in white Europeans. Rebound after stopping is something that we know, works with higher concentration, and long-term data up to 20 years show no permanent ocular or systemic complication. So low-dose atropine is really safe, and the best balance of efficacy, tolerability, and rebound effect sits between 0.01% and 0.05%. The STAR trial is the first large phase 3 randomized clinical trial with pharmaceutical-grade atropine in a mostly Caucasian population. 847 children across 47 European and US sites. Honestly, it feels a critical evidence gap. Regarding efficacy at 24 months, both 0.01% and 0.03% significantly slowed progression versus placebo in terms of annual progression rate that represent how fast myopia is progressing on a yearly basis expressed in diopter per year. And the greatest benefit was in the fast progressor. Effects were visible by month 6 and sustained through month 24. The safety profile was really good, not serious event, compliance above 97%. Based on this data, atropine 0.01% received EMA approval in June 2025 for children aged 3 to 14, progressive at least 0.5 diopter per year. And I think this is a major milestone for European practice. Just few words on the red light therapy that use 650 nanometer laser, 3 minutes, twice daily. Early Chinese randomized clinical trials show impressive result, 69% slower axial elongation and increased choroidal thickness. So they found a strong effect in high myopia and modest rebound on stopping. However, some concern about safety have been reporting, such as reduced cone density, drusen-like foveal signals, and frank retinal damage in some children. So thank you very much. And I'd like to close with a concept. So I think that I believe that there is no longer reason to avoid managing myopia. Maybe so you can maybe undecided about what to use, but you should not be undecided about whether to use something, because in every published studies, the single vision lens group got worse. So thank you very much.
So great thanks for the talks, and now that's the point, because we have a lot of questions. I will try to answer, to send you the questions as easy as possible. And I will go on you first, Annegret, because I have two questions which are really similar. One is, will wearing sunglasses when outdoor reduce the protective effect of sunlight? And the other is quite the same. Sunglasses for little kids, even toddlers and babies, have become very common lately. Do you think this has an impact of myopia onset? So the question is really, do we have to put the sunglasses, or do you think that it will reduce the effect of the outdoor activities?
So the sunglasses really reduce and filter out UVA and UVB, so the short wavelength. That's the main effect. And as such, they are not going to affect the development of the eye or hamper the efficacy of the sunlight. So they are important. And the other thing to consider is that today's children have a very, very long life expectancy, and there is quite a good evidence base that the UV light in the sunlight damages our retina cumulatively as we get older. And if these children grow to the age of 90 or 100 or even longer, then it's quite important that we provide UV protection so that they don't have to deal with age-related macular degeneration later. So as always in medicine, it is balancing, but I do not think that the UV filtering standard sunglasses for young children have any impact on the efficacy of the sunlight.
Okay, great. I think maybe we can add that there is also defocus sunglasses, so it can be useful too. I think really that's a good point. So Thank you for the answer. There is another question which is very interesting also by environment. So should the rule for limiting screen use also include reading paper book?
Well, the time that children spend on paper books is shorter. So in terms of mechanism, yes. They shouldn't spend 6 hours non-stop on reading books either. So it is probably the working distance that has to do with the mechanism, so the accommodative effort, and what that does to the choroid and the triggering of scleral remodeling. So yes, long times on books are also bad, but that's more a message to teachers and those children who are avid readers. And that is where the idea comes in to have a break every 20 minutes or so and relax your accommodation and look in the far distance. But the bigger problem with screens is that the time passes very quickly when you are on a screen, and not in the same number of children. The same is true for books.
I think also the screen about the light are different. And so if you just ask the children to read the paper book at a long distance and also with a good light, I think it's much better than the screen that just impact really, they really impact the vision and attract the children. So I really think it's a different impact. But it's very difficult probably to demonstrate, I suppose. So very good. So there was a question about, the question was also why defocus spectacle lenses are really contraindicated in strabismus. I really think that's important also to know that when you have defocus spectacle lenses, you have this area in the mid-retina that can impact, of course, when you have one eye, it will be in the blurred vision. So the impact is not very good because you will have the macula on the way that you defocus. So I really think it's not appropriate. And we have low-dose atropine, we have contact lenses, and we have other devices or systems to control myopia. So I really think it impacts because the zone is not the good one in the eye, which is in strabismus. There was also to say that there is a question about the defocus spectacle lenses for Professor Vagge, Aldo. Don't you think it's very important to choose a system which has a real research study, a real accurate one, robust, and also to make more importance with long studies with the system? So what do you think? What is... What we can propose for the practitioner?
Yeah, I totally agree. Absolutely, we should know that not all the focus lenses are the same, and in particular, I can say that we have 2 generations of peripheral plus spectacle lenses. Cochrane called peripheral plus spectacle lenses. They're the focus lenses. We have the peripheral hyperopia reduction lenses, basically the hyperopic, the perifocal lenses, sorry, that we know that they have an efficacy that is pretty low, 3.5%. And then we have the simultaneous defocus design lens, so the DIMS, the HALT, and the CARE lens, that they have shown an efficacy of about 50%. So in my clinical practice, I agree with you, I exclusively use simultaneous defocus lenses. I don't use the peripheral lenses because I think that are not too much efficacy. So I can choose better.
Thank you. That's very important. And there is also a question, I think, for you, but it could be for everybody of the experts there. From what age do you start the treatment with special glasses and atropine? 6 years or earlier? I think you can answer also with the studies, because we have a study that demonstrates earlier age. What do you think in the study, Aldo?
Sorry, I didn't heard you.
Oh, I will again.
Can you repeat the question?
From
Yes,
what
thank you.
age do you start the treatment for control myopia for the defocus lenses, glasses, and also atropine?
Okay.
6 years
Okay.
or earlier? And I was saying that it's important to look about the studies and what
Absolutely.
we know.
Absolutely. I think I start earlier. And we know, I mean, especially in the last generation of the focus lenses, that they included the patient from 4 years old. And I think that we can imagine myopia until 18 years old, and with the focus lenses. And with atropine, I start from 4 years old, and I stop treatment at 14 years old. This is my strategies.
Okay. Do you have any something to add, Annegret, also to see if we have in the same practices? Because I know practices are sometimes not so easy to be similar.
So the problem is the absence of evidence, right? So we are pretty sure the effect will be the same, but we are not so sure because children of younger ages just can't take part in clinical trials because the assessments take several hours in a proper randomized controlled trial with cycloplegia at every visit, etc. So younger children are simply often excluded from the trials just because they can't cope with the study assessments. So that doesn't necessarily mean that the interventions don't work. I think the very young ones we are nervous about because their visual system is still maturing, and we know it's a feedback system. So we don't want to give them blurred vision 7 days a week because we still want them to develop high resolution, acuity, etc. at close range and at distance. So it is difficult, in my opinion, to draw a cutoff line. I think it does depend on the overall, as you said, Dominique, visual and orthoptic assessment and many factors, and having excluded underlying factors in the very young children that might include additional investigations to rule out retinal dystrophies, etc. But I don't think I have started a child younger than 4 years of age either. Even if it is just because we are so busy organizing all the tests to convince ourselves that it really is simple myopia.
Yeah.
Thank you very much. I think I have quite the same thing, and I think that I just begin after 4 years old, and also I consider they are fast progressors. Because sometimes, of course, you see there is a fast progression of the myopia, and so you need a treatment, and so you are waiting for that. But be sure these fast progressors are not myopia disease. That's very important too, and you rule out the syndromes and also retinal dystrophies or some other pathology. So I think really this is important to consider, and to have this cutoff is not exactly. You are absolutely right. It's not a real cutoff 4 years old. You must consider every point. I have probably one of the last question is I would like to ask about the opinion about contact lenses for myopia management, compound with contact spectacle lenses, compound with contact lenses for myopia with glasses. You know, when you associate spectacles defocus and contact lens defocus, what's your in this compound therapy? What do you think? Aldo, I think the question is for you, because I don't think there's a lot of studies for the compound spectacles and defocus contact lenses.
Absolutely. Usually I manage it's very rare that I prescribe both strategies in the same kids. Only it can happen only maybe in some athletes that of course cannot wear glasses for a lot of time due to the sport activities, but otherwise I decide to choose from one strategies or to the others. I mean, it's And also we know that we should wear DIMS lenses for at least, or DIMS halt on care lenses for at least, 12 hours per day. I know, but if a patient usually do some sport activities 4 hours per week, I think that doesn't matter if they don't use the glasses for that activities. So,
thank you for that. One more question, just one more. The question is, how do you decrease atropine low dose treatments to avoid, to avoid rebound?
Okay, usually if I always start from 0.01%. In this case, I do not tapering the atropine. Studies show that we don't have a rebound effect. If I start from 0.05%, yes, I can tapering the atropine just to avoid a rebound effect. Maybe I switch to 0.01% and then I stop. Okay, good. Do you have the same thing to Annegret, or do you taper differently?
The only difference is that in my practice, I mainly see very fast progressors who are progressing despite optical interventions. So I prefer to start with 0.05%. And then at the end, when things have stabilized, when myopia progression and axial elongation stabilized, then I like to go to 0.01% for a year and see that it remains stable before I then discontinue completely. And then I have to say that many young people at that stage then still stay on their optical treatment for longer.
Okay, so I think we are in accordance. So thank you. I think really would like to thank all of you, all the speakers and the participants. It was really a great web conference. I would like really to encourage you to go to the website of EuMYS. You will find very different contents every time, I hope so. And this is our mission, to exchange connecting experts, to support education, to encourage research and creative opportunities for dialogue. So, this is not the only one step on our ongoing journey, because EuMYS will continue to provide the contents, and the next step is really the annual conference on the 9 and 10 of April in 2027 in Paris. So I would like you to come, and it will be great if we can connect all together. So all my gratitude to all members, to supporters of EuMYS. And again, thank you for the participants, for the questions, for your dedication and the support you bring to EuMYS. And I really look forward to meeting you again very soon. Thank you very much to all.